Everybody okay?
Yes, sir.
Okay.
Yes,
Thank
sir.
you. So, first we see a picture. This is the urinary tract. So, that urinary tract consists of one pair of kidneys and one pair of ureter, one urinary bladder, and the urethra. So, both the kidneys lies in the abdominal cavity near the posterior wall. So, the position of the anatomical position of the kidney, everybody must remember. Otherwise, you don't correlate the physiology and pathology. The kidney main function is to filtrate the blood and blood products, excrete the waste products, and expel out to the exterior to save the life. So it is an essential organ for survival. So both the kidneys are not in the same level. Show the picture. The right kidney is a little bit lower than the left kidney because on the right side the liver lies. The right lobe is there enlarged in size. For that reason, during development, the kidney is descended down to some extent. The left lobe of the kidney is lower. So the kidney is composed of, there on the cut sections you show, there is a cortex, then medulla, and after that the tube-like structures which can collect urine from the kidney to the exterior. So this is two smaller ones, these are called the calyces. So initially the pointed projected part, pyramidal shape is called the renal pyramid. From the renal pyramid, the tubules drain urine from the pyramids to the calyces. That calyces join together to form from the minor calyx, they form the major calyx, and ultimately the major calyces are join each other and form the pelvis. That pelvis go down. This part is called the ureter. This ureter is started from the pelvic junction. It started and ends at the trigone. In the trigone, there are two openings within the urinary bladder, and last part of the ureter is obliquely enters inside the urinary bladder wall to maintain some functioning and functioning work and prevent the vesico-urinary reflux. Because whenever we micturate, the intra-abdominal pressure is raised, the urinary bladder is contracted, the raised pressure can expel out the urine from the bladder to the urethra and go exterior. So whenever the intravesical pressure is raised, if the ureter is not obliquely enters into the urinary bladder, the urine can migrate it up and go into the ureter bag, and which can causing back pressure effect over the pelvis and calyces, which is called the vesico-urinary reflux. For that reason, the God, during manufactured the body, this part of the ureter is entered during development. It enters inside the bladder obliquely and from the exterior and go inside the mucous membrane, and there is opening. It is called the ureteric opening. So these are about the anatomical delineation of the urinary tract. The length of the ureter is about 25 to 30 centimeters, usually 25 centimeters in an adult. It may vary according to age of the patient. So this is the urinary anatomy and of the ureter kidney, and enters into the urinary bladder. The bladder is communicated with the exterior with the opening, which is called this is connected with the urethra. That urethra having, according to the sex, there is a different types of parts, different parts. So from the neck, there is a triangular part where the urothelium is firmly attached. It is called the trigon of the urinary bladder. Trigon of the urinary bladder. And another important thing is, always remember, the lining of the epithelium from the urinary bladder to the renal pelvis, that means calyces of the renal pyramids, the lining is the transitional epithelium. That epithelium having a capability to shrink and convert it into a multilayered. Whenever stressed, it converts into a single layer. And that epithelium having no absorbing capacity. It is the basic difference to other epithelium lining. Then, for that reasons, the transitional epithelium, all the solids of the urinary bladder is not absorbed through the bladder, from the bladder to the systemic circulations. Now we can discuss about some anatomical constrictions of the urinary tract. That means the ureter having some, during course there is some anatomical constrictions. So look that picture. There is a marking that there is some anatomical constrictions. That means that constrictions can help the urinary tract to raise the intraluminal pressure. And also some disadvantage of the constriction is, if there is any stones, the size lies above. When you are passing that side, the side is narrowed. For that reason, the pressure having the patient having some constriction, that means causing some obstruction there, and the patient feels pain. So that constriction is also helps, because if there is a constriction there, whenever the urine is passes there, there is, during peristalsis, there is more pressure there. But whenever there is a stone is obstructed, that obstruction causing the patient having back pressure change over the pelvis and calyces and causing hydronephric changes. So the constriction sites are the ureter begin site, that means ureter pelvic junction is the one of the site of constrictions. The other side is whenever the ureter is running down and passing the that means iliac, crossing the iliac artery, then go down and backwards along the shape of the pelvic cavity and go down in the pelvic floor and ultimately enters into the urinary bladder. Before enters into the urinary bladder, there is, in case of male, the vast difference from the seminal vesicles, like that manner, go up and crossing the ureter and go upwards and enters into the spermatic vessels. So during crossing, that causing some pressure effect there, and it causing some constrictions. For that reasons, one at the pelvic junction is constrictions. The second one is where the great vessels crossing the iliac artery, and then third one is the juxtaposition of the vas, or in case of female, the broad ligament. Last one is the intramural part, and lastly is the opening of the urinary orifice. So these are the constrictions side. These are the anatomical constriction of the urinary tract, upper urinary tract. So whenever the stone is dislodged from the calyces, go into the pelvis, there may not be pain, but whenever the stone is passes from the pelvis to the upper ureter, whenever passing that constrictions, at that time the patient feels pain, and suddenly the pain become absent, declining, because the constriction is crossing by the urine pressure on the upper tract. So whenever the stone is passes from these constrictions, there is no pain. The pain is declining. Again, after a few days or few hours or few months, the patient feels pain. The second pain is that constriction side. And again, there is no pain relief period. And after that again pain, you think that is the constriction side, the stone is passes. And if you count the pain history, you can make calculate where the stone is now. From the taking of the history of the patient. And another one is, and lastly, the patient, when the stone enters into the urinary bladder, that means there is severe pain, and that pain is different from the other pain is that upper 1, 2, 3, 4, that three position of pain is usually radiate from the loin to the groin. That curve manner, the pain is shifted from loin to groin. But whenever the stone enters into the urinary bladder, the pain is radiated to the tip of the penis or tip of the clitoris. That two pain indicates that the stone is most likely enters into the urinary bladder wall. That means transluminal part of the ureter. And that pain radiates towards the glans penis or the penis or the clitoris. So these are the presentation of the pain, and also you can locate the stone level from the history of pain. And that when the stone enters inside the urinary bladder, then the patients feel relaxed. There is no pain. But the presentation at that time is, one is pain, another one is the patient present with some hematuria. That hematuria can be presented looking the urine. The patient can notice that he having a pain in the abdomen, and now the urine become red in color. So these two can mimic most likely the patient having stone into the urinary tract. And when the stone enters inside the urinary bladder, then the presentation is little bit different. The pain of the nature has become different, because when the urinary bladder containing the stone is, when the patient is standing, the stone is go down. But whenever the patient is lying, the stone is on the posterior wall. So when the posterior wall, near the posterior wall, beyond the trigone, so the patient does not feel any source of pain at the resting time. So the pain is presented during the working hour. Some books is written there at the daytime, but the daytime is not always all the people, because some people having a night guard. He can sleep at the day, so the presentation at the working hour is the best of the answer. And sometimes the stone is smaller in size, suppose 1 centimeter, 1.2 centimeter. In that size of the stone may impact in the bladder neck, and the patient may present with acute retention of urine. But whenever the stone size is bigger enough, so the bigger stone is causing the presentation a little bit different, because the stone may not produce the acute retention, because it does not possible to enter inside the urethra. So the stone lies within the urinary bladder, don't completely obstruct the urinary neck of the urinary bladder, the urethra. For that reasons, the presentation is interruption of the urinary flow. So your answer is urinary bladder stone is presentation is pain or dysuria at the working hour, and interruption of urinary flow during at the working hour. Interruption, not the acute retention. But in case of smaller stone, the presentation associated with it may present it as an acute retention of urine. So when the specimen is a big enough specimen given in the exam, that means in case of a specimen of OSPE, so look the stone size is. So that stone size is never ever can possible to enter inside the urethra. So the presentation of the patient does not any time with acute retention. Be careful about it. Your answer, it is called dysuria and interruption of urinary flow during micturition. Whenever the patient micturate, some urine is expelled out, then the stone is heavier, it goes down, it can block the opening. And when they change the posture, the stone is dislodged from the opening to the side, then the urine can easily pass. The presentation is disruption of urinary flow. Video. So, what are the types of the what are the types of renal stones? So you show, this is a picture of the renal stones. It takes a particular shape of the stone. The name of the stone is staghorn calculus. But the types of the stones are, there is some oxalate stone, phosphate stones, calculus, uric acid and urate calculi, cystine calculi, and xanthine calculi. The oxalate calculus are irregular in shape, covered with sharp projections, which causes bleeding. The color of the stones become changed, it becomes pigmented, that means brown in color. So the oxalate stones are rough, irregular, and the phosphate stones are smaller. Then the phosphate stone, composition of the phosphate stone is calcium phosphates, it may, or combined with ammonium, calcium, ammonium, magnesium phosphate. And that stone is laminated in appearance. The bladder stone picture is the phosphate stones, and it develops in an infected urine. And uric acid and urate calculi, this is reddish brown in yellow or reddish brown in color. This is radiolucent. A previous two is oxalate and phosphate stones are radio opaque. And cystine calculi are uncommon. It may develop, and these are the yellow. When it is removed, it may change color, change to greenish hue when exposed to air. And some are xanthine calculi are extremely rare. So common stones are oxalate calculus and phosphate calculus. The staghorn calculus is the phosphate stones. So look the pictures. There is, the appearance is looks like the deer child horn, which is called the staghorn in appearance. The horns represent the shape of the calyces. The smaller one is the minor calyx, then it is the major calyx. So joined with the two minor calyx go into the major calyx, and ultimately joined with the pelvis, and it may take the shape of the staghorn calculus. That staghorn calculus presented persist in the body without presentation in a long time, because it develops slowly, layer by layer, but deposited and increase the size. For that reason, it does not produce gross obstruction of the outflow of urine. For that reason, that big size of the stone can capable to persist in the body without having a mass symptom. For that reason, the patient carries stones long day, because when the stones presented more, that means the feelings of pain more, the patient can early go to the doctor and demanded treatment for recovery of the diseases. For that reason, large staghorn stones can carry the patient a long time. Yeah. So these stones, renal stones, having the quality is, it is radiopaque. 90% stones are radiopaque. For that reason, a simple X-ray can capable to diagnose the renal stones. But the gallstones, in comparisons, 90% gallstones are radiolucent. For that reason, for diagnosis of gallstones, we don't go for plain X-ray abdomen. We straight go for ultrasonography. But here, for renal stones, directly you go for plain X-ray abdomen for early and easy detection of the urinary tract stones. Look at the picture. This is the plain X-ray of KOB region. Plain X-ray of KOB region because in the picture there is no written there any of IVU is written. But in case of IVU, contrast X-ray, before doing the contrast X-ray, we usually do a control X-ray. So in that cases, they are written somewhere in the corner is a control film or the pilot film. But here, there is not anything written like control or pilot. So only there is a marking the right one. It is not the ideal X-ray, because in case of ideal X-ray, the identity of the patient must be written in the film. The ID number must be written there, and the name of the patient also written there. The date and time must be written there. The technologist's name also must be written there. Otherwise, the film is not ideal one. So there is no written in the control film. So we can believe that that is the plain X-ray film in KOB region. It is the KOB region. For that reason, I say it is KOB because the diaphragm is not visualized here. The lower part of the chest is not visualized here. They are mainly focused the pelvis and the lower part of the abdomen. For that reason, it is a plain X-ray KOB region. That picture shows that there is a radiopaque shadow which lies on the right side of the abdomen. The level of the vertebra from below you count, this is a fifth, this is fourth, this is third, this is second. That means second and third, and the level of the second and third lumbar vertebra. So in the second and third lumbar vertebra, whenever a radiopaque shadows seen in the right side, we always directly can give the comment that it is a renal stone which lies on the right renal stone. So it is very close to the transverse process. For that reasons, we easily directly say most likely the stone lies in the pelvis of the kidney. If the stone is placed on the far away from the midline, like here, here, or here, in that cases, your comment is it is stone is most likely in the renal stone, most likely on the calyces. So it is the big stone very near to the transverse process of the vertebra. For that reason, from the plain X-ray, your comment is it is right renal stone, most likely in the pelvis. So this film is not the ideal one. We look and see the other films. Closer. So everybody can understand? Okay, thank you. Next. So look, this is another X-ray. This is also a plain X-ray KOB region. That marking is the right here. So this is the right side, this is the left side. So one thing always remember, the difference between the plain X-ray abdomen and the plain X-ray KOB region is the plain X-ray KOB region X-ray done on a lying posture. We remember it. It's very important question, because if you don't understand the things, you can miss during operation. The stone may not in the proper site. So we do the surgery in the lying posture. So at the lying posture, the X-ray represented the exact position of the stone is. For that reasons, we do the plain X-ray KOB in the lying posture. But in case of intestinal obstructions or the perforations, the X-ray needed to do in a plain X-ray abdomen in erect posture. Because without erect posture, we don't able to see the free gas cannot be possible to diagnose because the air, whenever we are standing, they migrated up under the diaphragm. For that reasons, plain X-ray abdomen in erect posture. And in case of intestinal obstructions, whenever we need to diagnosis, there is the fluid level needs to see in the X-ray. So without standing posture, we don't able to diagnose the fluid level properly. Because whenever we stand, the intestine in a coiled manner, like that way is placed in the body. So the air is go up in the tubes and fluid in the down. For that reason, in a step ladder pattern or at the side, the fluid level seen in a plain X-ray abdomen erect posture. For that reason, we do an X-ray in a erect posture. This is a normal one. But in case of serious patient don't able to move standing in posture, in that cases you can go into another position which is called lateral position. In that cases we can easily do the diagnosis by seeing the X-rays. So these are the abnormal position. These are a normal one. So this plain X-ray QB, we look the picture, plain X-ray QB region showing the kidney, ureter, and bladder regions. Showing there is a radiopaque shadow on the right renal region, which represented the staghorn in appearance on the right side. On the left side, there is a radiopaque shadow, which is lying on the left side at the level of the lumbar 1 and lumbar 2 vertebra, far away from the transverse process. And no other radiopaque shadows seen in the ureter. So look, there is a ureter line. This is the ureter line, and this is the bladder region. No radiopaque shadows seen in the other area of the urinary tract. And in the midline, sometimes in the plain X-ray QB, there is some stone in the prostatic urethra just behind the symphysis pubis. Here maybe sometimes stones there. So this is not the ideal QB because whole of the pelvic bone must be seen in the QB region, X-ray. So it is not the ideal one. And by looking the radiopaque shadow, we can guess easily where the stone is. And after that, it is the preliminary investigations. From that, you can guess there is the stones there. So you can correlate the symptoms. Then you go for further investigations. That further investigations can reconfirm you that where the stone lies. Then you go for the treatment plan. How can you remove it out? And how can you prevent the stone formations? These are the subsequent protocols. Next. So this is about this is plain X-ray QB. Look at another one. You can go in the little bit later. Next, I go in a plain X-ray in the pelvis. So this is the plain X-ray pelvis. This is not the QB region, it is the bladder region. That means this is the pelvic X-ray. Plain X-ray pelvic region shows a laminated. Look, there is a black, white, black, again white, again black, again white. There is a laminated radiopaque oval shape shadow in the pelvic cavity, which represent that the patient is a urinary bladder stone. That means vesical calculus. If it is single, it is called the calculus. If there are multiple, it is called calculi. Be careful about it. In the examination, most of the students can confuse at the time. Single number, calculus. Wide, large word, calculus, single number. If it is multiple, small word, calculi. This is easy to remember. So, by looking the plain X-ray of the pelvis, you can easily guess the X-ray is a male patient because the penile representation of the soft tissue shadow is here. Sometimes some examiners may ask in the x-rays, is it male or female? So for that reason, whenever you look the picture, be careful about on the surroundings of the picture is. So that you can easily answer the answer is. So it is a phosphate stones there. Next. So everybody understand? Hello? Yes.
Yes, sir.
Thank you. Yes. Next. So look at another picture. The previous X-ray, there is not given any source of contrast. This is a plain X-ray, and this is also an X-ray, but the X-ray is called the computerized tomography scan, CT scan. So this is a CT scan film of KOB region. This is plain CT KOB region without contrast. Without contrast CT scan. So somebody in the exam sometimes asks, how can you say it is a plain CT? So your answer is, there is no contrast in any picture, contrast enhancement, or the urinary tract contrast is films showing in the picture. For that reason, I say it is a plain X-ray, plain CT KOB region. So in the CT scan of the KOB region, first the CT scan done without contrast. Then push the contrast and go subsequent film, which is called the contrast CT. CECT, contrast enhanced CT scan, CECT of urinary system. So this is a plain CT KOB. You look the picture. This plain X-ray just looks like a plain X-ray, nothing else. But the image quality is so high because high resolution film is for that reasons. So whenever we diagnose the renal stones, we are searching the site of the stones are in the renal area, that area, in the ureter line, okay, that area, and the urinary bladder. So look that picture. So normal ureteric line in the transverse positive, there is no radio-opaque shadow. No radio-opaque shadow. If you do an ultrasonography in that particular patient, the sonologist can give the information that there is no stone seen in the urinary tract system. Always, almost. Because if you see the subsequent film of the CT scan, then you can easily evaluate where the stone is not located in the ureteric line. Because suppose there is a stone seen here, and that stones, if you see in the control film, it go into the medial side, not at the normal anatomical place. Okay, understand? Hello?
Yes, sir.
So this stone is not in the normal anatomical side. It go into the leg, pushed medially. Why the stone is pushed medially? Why? If you know the pathology, pathogenesis of the stone and subsequently effect, you can easily realize that all the time the stone is not possible to see in the normal anatomical position. This is why, because this is the ureter, this is the pelvic junction, and this is stone lies at the level of the first, second, third, fourth and fifth lumbar vertebra. Yeah. In the very beginning of the obstruction of the stones, the stone must be lies here, that level. whenever the stone is not capable to pass down, in that cases there is a effect of back pressure obstructions causing dilatation of the ureter and dilatation of the pelvis and calyces. That dilatation causing ureter become tortuous, kinked, and that stone is heavier. For that reason is pushed medially and displaced medially here. So in a normal anatomical landmark, if we search the stones, we cannot see at the line. For that reasons, it is better to do an CT scan than an IVU or a plain X-ray for more confirmatory diagnosis of the urinary stones. Another advantage of the CT scan is, if you suppose a stone is here over the bones, you don't able to see in a plain X-ray because there is superimposed in the bones, so there is a no marked shadow there, radiopaque shadow there. For then you can miss it. But the ultrasound give the information that there is ureter adenosis. So if we don't diagnose the stone, then we can think that the stone obstruction is the obstruction is the cause the stricture of the ureter. But the stricture of the ureter is very rare. For that reason, any confusion whenever in a plain X-ray or the ultrasonography give the information that there is no stones on the hydrophobic kidney or ureter, in that case they must do a CT scan. So you compare with the, you can compare with the left side, there is a gross hydrophobic change, but the patient, the creatinine is 4. So if the creatinine is 4, it is contraindication to do the contrast CT or IVU. So in that case, how can you manage the patient is? So previously, whenever there is no CT scan, in that case, that type of lesion cannot be possible. The level of obstruction is detected by without seeing the picture. So in that time, it's very difficult to diagnose. So that patient, or no, that patient is treated by me in a private clinic without doing an IVU. You look, this is the content which lies inside the kidney. So that means you look, the evidence is this is the pus. So this is pyonephrosis. So the complication of hydronephrotic kidney is a pyonephrosis. So that pus, the pus is removed by removing the stones. Or no? Oh, it's a picture of. Close karo. So that remove the stones by doing laparoscopic ureterolethotomy, transperitoneal approach, and stone is removed and all the pus is escape out by suction from the ureter and pelvis and go out, then putting a stent, close the ureter, and the patient return creatinine within 15 days. The urine output increases and the patient become healthy, and after 1.5 months remove the stent. Next. So this is about the CT scan and the plain X-ray. Now we discuss some investigations of IVU, because this is very favorite investigations all of the surgeons of general and laparoscopic surgeons. So look that picture. The film is shown in the previous. There is a stone on the right side, stone on the left side, no stones there. But here, we look the subsequent films. So everybody must know the preparation for IVU, intravenous urography. So intravenous urography, before doing the intravenous urography, always patient needs to gut preparation. The gut preparation is needed for that reason is, you look the picture is the first one. So that plain X-ray control bin, whenever first do the X-ray, what are the thing you look? You look the kidney, ureter and bladder region is free of fecal matter and free of gas. Because if there is gas there and fecal matter loaded there, the stone may superimpose with the fecal matter or the gases and the vision is not clear one. For that reason, preparation is needed. The preparations are, the patient needs raw cereal diet and some laxatives at the night. 2 days preparation is the best one. And another thing is preparation is, before doing the IVU at the morning, the patient must be needed to fasting. The fasting is needed because if you ingest 3 glasses of water just before the IVU, the bladder, the urine is more volume is production is there. The concentration of the dye become declining and the picture is not well and good. For that reasons, at least 10 to 12 hours fasting is needed. Sometimes somebody does not prepare the patient, does not advocate the patient, does not cooperate with the patient party. You must say from 10 p.m. nothing can throw mouth. Not a plain glass of water also. Because the water, if you don't take, then the patient becomes dehydrated. Whenever push the contrast through IVU, the urinary tract is more better to delineate. More urine is filtrated, concentrated, and easily can delineate the ureter and the bladder and the pelvis. Another important thing is, the composition name is iopamiro. Previously, the drug is more hypersensitive drugs, iodine contrast agent. The new preparation has iopamiro. This is ionic. These are the less allergic one. This is called the non-ionic contrast. If you inject the drugs, then after injection, whenever push, completion of the injections, immediately take the X-ray. The lot of X-rays can taken because whenever you inject the drugs in IVU, just after putting the drug inside the body, the blood is circulated through the heart, go to the kidney, through the renal artery, perfuse the kidney and filtrate through the renal tubules, then accommodate in the calyces. So immediately the nephrons are taken the dye and the picture is called the nephrogrammic phase. Then whenever the pelvis is visualized, the pylographic phase, then ureter is visualized, then the bladder region. Whenever late film is taken, the bladder is full. So lot of film are taken 5 minutes, 10 minutes, 15 minutes, 20 minutes, half an hour, 1 hour, 2 hours, 6 hours, 10 hours, 12 hours. So 10 to 12 hours, these are the taken whenever no dye is passes from the renal kidney, pelvis or calyx kidney is not visualized on one-sided. At that case, the late film is needed to take it. 12 hours, 24 hours is needed to give the opinion that the kidney is non-functioning or non-visualized. If you don't see any contrast on that side, you never ever say the opinion is it is non-functioning kidney. No, it is non-visualized kidney. That non-visualization may be congenital absent, or it could be done operation previously for any other diseases. for the two reasons, or the patient with the kidney become non-functioning. For that reasons, by looking the IVU in the early film, never ever give the comment. In the late film, never ever give the comment that the kidney is non-functioning. No, the kidney is non-visualized. The non-functioning kidney is give the opinion by correlation with other investigation like ultrasonography, and you can do the isotope scanning. These are the two core mixed together and give the opinion that the kidney is functioning or not. So these are about the ureter. But IVU, you look, one thing is, there is a, if you compare that side, on that side, the pelvis is smaller in size, but the calyx is larger in size. Look. So the calyces, this calyx is enlarged in comparison to the pelvis, but usually it is not the common phenomenon. Commonly, the calyces are smaller, join together to the calyx and go form to the pelvis. So pelvis is larger one. But here, the calyces is larger one. Why the calyx is larger one? So easily you can understand. For that reasons, the definition of hydronephrosis is aseptic dilatation of the kidney or part of a kidney. Aseptic dilatation of the kidney or part of a kidney due to obstruction at the outflow of urinary tract, either incomplete or intermittent obstructions. That means a big small stone impacted in the neck of the pelvis. If it is not dislodged, that back pressure causing increased pressure in the pelvis, back pressure to the renal parenchyma, and that causing ischemia, that causing become kidney die. So for hydronephrosis needs the production of the urine, which in the calyces on the pelvises, it go down in comparison with the outflow of the tract. That means in the calyx, there is ostium of the calyx, is the outflow tract. In the pelvis, is the pelvic junction of the outflow tract. So if the pelvic junction is narrowed, so the urine which is produced by the kidney is not capable at the same time go down. So they're remaining inside there. For that reason, subsequently there is increasing in size, gradual adaptation of the pelvises and dilatation of the pelvis, which is called hydronephrosis. For that reasons, in the previous books written in the definitions is like that. But the new book written, the definition is not the correct one. This is my opinion. So here, look, the staghorn stone is formed here. So the ureter is not visualized. Look, not a single picture is not visualized there. So if the ureter is not visualized, for that reason during IVU, there is some technical work done for visualizing ureter is, the patient is lying posture in the table, head little bit tilting down, and one of the binder is applied over the abdomen during IVU, causing increase in intra-abdominal pressure. So if the increase in intra-abdominal pressure, that increase in intra-abdominal pressure causing some pressure over the ureter, and which causing the ureter is possible to visualize to some extent. If whenever the ureter is not visualized, then the technologist can take that type of techniques. So whenever there is staghorn stones there, so your obstructions diagnosis is at the pelvic junction. So PU is a obstruction. This is one of the cause of urinary tract obstruction. Upper urinary tract obstruction is pelvic urinary junction stone obstruction, junction obstructions. So why needed to know the cause? Because this is a big stones there. So if you do the surgically, you can remove it out, either minimal invasive or open or any other measure. But if you don't treat the pathogenesis, the cause of obstructions, there is every possibility to return the stone formation. For that reason, the etiology must be known where the stone is there. The stone is there due to the PUG obstruction. For that reason, you remove the stones and you need to treat the pelvis and pelvic junctions. There is some treatment needed which is called Anderson-Hines pyeloplasty. Anderson-Hines pyeloplasty. That means you cut the pelvis to some extent, cut the ureter. The ureter is implanted in the lower pelvis and the pelvis is smaller in size. So there is more pressure, it can easily, the ureter is expelled down. The ureteric opening is wider during the contractions. For that reasons, we do the Anderson-Hines pyeloplasty in case of hydronephrotic kidney if the stone is due to the obstruction of the pelvic junction. So this treatment is needed. So obstruction, if it is a pelvic junction level, the cause is PUG obstruction. That means is agenesis, or that means that area become congenital, there is abnormalities there. And another important thing is, if there is a hydronephrotic kidney due to the PUG obstructions, then you compare with an individual who having a belly over a belt in the lower abdomen. Whenever you put a belt in the lower abdomen, the belly can protrude down over the belt. So the belly is make pressure over the belt and causing more pressure over the pelvic junction. That means if there is associated with, there is a accessory renal vein there. Normally the vein, artery, pelvis. Vein, artery, pelvis in relation, but there is the extra vein is there, so there is a fork-like effect. So that fork-like effect usually not produce any obstruction. But whenever the associated with PUG obstruction, the pelvis is dilated, then is hang down over the vessels and causing pressure effect and causing the fork-like effect. So in that cases, the vessel can need it to disband in case of vein, but in case of artery, the artery is not possible to divide it, because if you divide, to some extent the nephron become damaged of the lower part. So the treatment of PUG obstruction is pyeloplasty. A lot of techniques are there. The commonly for an undergraduate is a Anderson-Hines pyeloplasty. But nowadays, the treatment protocol is more sophisticated. They can by the laser or the pneumatic lithotripsy, the stone is broken down, and all the stone fragments are removed without with the wash through the tubes. And along with that, they do an endoscopic pylotomy. That means introduce the endoscope, make an incision over the pelvis, just mucous membrane, and to some extent the muscles. So this is the latest endoscopic treatment for PUG obstructions. But older version is for Anderson-Hines pyeloplasty. So Anderson-Hines pyeloplasty is for undergraduate is sufficient one. Next. So look one video, be carefully.
Your doctor has recommended that you undergo a stone removal procedure called percutaneous nephrolithotomy, or simply PCNL. The goal of this procedure is to remove all your kidney stones and, when present, your ureteral stones. This animation shows the removal of stones in the kidney. PCNL is carried out under general anesthesia. When you are fully sedated, a catheter, which is a hollow tube, is placed in the bladder. The bladder catheter drains the bladder and remains in place with the use of an inflated balloon. Another catheter is placed up into the...
So this is another catheter, which is called the uretary catheter. So it can go up at the level of the pelvis. This is given because during PCNL, from the up on the back of the kidney, through this uretary catheter from the exterior, they can push normal saline, so the pelvis is more wide and easily can they penetrate inside the calyceal systems. So for that reason, the uretary catheter is there. One thing. Another thing is, so this uretary catheter can prevent the dislodgement of the fragment from the pelvis to the ureter. And after completion of the surgery, they remove the catheter and put a stent from the down to the up. So look, the
ureter. Look. Through this catheter, a contrast dye may be instilled to allow a better view and exact stone location and to facilitate access to the kidney, while your urinary tract is visualized using X-rays or ultrasound. Once the stone is located, access to the collecting system of your kidney is gained.
So this operation done under the fluoroscopy control. Fluoroscopy machine is needed or ultrasonography machine is needed. If expert enough, ultrasonography probe can easily, by looking ultrasonography, they can give a single puncture needle inside any of the calyx. It depends upon the choice of the surgeons. They enter the calyx from the renal regions. That means 12 ribs and ureterospinal laterally. That through this point they can enter with the guidance of the X-ray, that is fluoroscopy or ultrasonography. That first enters the needle there. So after entering the needle, the urine is came out from the exterior. They can easily diagnose. They are achieved their success to go into the calyces. Then over there they introduce the sheath, and subsequently the sheath changes. From that size they go into larger one, like a thumb of size sheath can easily introduced into the calyces. Then you look the
using a thin needle.
So
this access route is carefully dilated.
These are the dilatation. There.
The guide wire allows the nephroscope to safely access the kidney. Some stones can be removed directly using a grasper. Larger stones need to be fragmented first, using a device like a laser before extraction. After removal of all the stones, your surgeon will perform a contrast study. When there is good passage of contrast material to the bladder, this means that the ureter is also stone-free.
If needed, multiple stones here and there, they can go do a subsequent puncture that area, wherever they need it. In expert enough, they can do a 2 or 3 puncture at the same sitting and clear 100% stones from the stones. But if the surgeon is an expert enough, he is not capable to do all the calyceal stones there. And after that, whenever the stones are clear, then they put a drain through this sheath to the pelvis, calyces there. Because this helps to drain the urine, one, to some extent after post-operative periods. Another one is, this is the tract. So this tract, whenever put a tube there, it can give a pressure effect there, then there is no bleeding subsequently there.
In some patients, a temporary small tube, called a double J stent, may be placed to ensure that swelling does not block the drainage.
This is important thing one. So put a double J, this one type of J, the another J is there. So that J can help the stent is stay there. Otherwise, if there is not J, by peristalsis, the stent can migrate down. There is another question is, how the urinary upper tract is drained into the lower tract. How? There is a 2 mechanism. One is by inherent peristalsis mechanism. Another one is by gravitational force. For that reason, if you are standing, if you are walking, there is easily urine can expel out from the kidney to the bladder. But if you are lying down, the urinary kidney pelvis is drained only by peristalsis. No pressure, no antistatic pressure there. So gravitational force there. For that reason, in lying individual, in the elderly patient, there is a more prone to develop urinary tract infection and stone formations. So that basic thing must be known. Another one is, in a question is, how can you identify a ureter in a living body or during laparoscopy? It can easily identify, because if you look in the posterior wall, that there is hollow tubes, the great vessels, also the hollow tube, gonadal vessels, also the hollow tubes. But in the gonadal vessels, there is no peristalsis. But here in the ureter, if you look to some extent, few seconds, there is some peristalsis, there is relaxation, contraction, relaxation there. That can easily identify this, it is a ureter.
Of the urine. The stent remains in place by J-shaped curls in both the kidney and bladder. At the end of the procedure, a nephrostomy may be placed. This catheter helps to drain your urine. The catheters and stent are usually removed shortly after the procedure. You can leave the hospital once you are able to empty your bladder sufficiently and you have no fever or pain.
So another important thing is, what type of surgery you done, any type of surgery in the urinary tract, always remember the patient in every case is developed pyrexia after doing surgery of the urinary tract stone operations. In what maneuver you do it? Because whenever you break the stones, at the center of the stones there is a bacteria lies. So whenever broke the stones, the bacteria become flare up from the center to the exterior, and you do the surgery, there is some trauma, some vascular channels are open up, so bacteria can migrate to the vessels and the patient develops bacteremia, septicemia. For that reason, be careful about the patient of the urinary tract surgery. Broad spectrum antibiotic always given, and if needed before surgery, do the urine culture and sensitivity. Next. So this is one type of surgery which is called the PCNL. This is nowadays the very favorite for every urology expert surgeons. It is very favorite surgery and very popular nowadays. The other options are, this thing is not needed for your exam, but it needed to learn your knowledge and reach your knowledge, and to prescribe your relatives or your father or mother or sisters what type of surgery needed for that type of disease. But it does not needed for every patient, every doctors, every student for the exam. This is another thing is RIRS. That means retrograde intrarenal surgery. Retrograde intrarenal surgery. This is one of the pictures. Look, retrogradely from the back down, go up. It is a flexible endoscope. From the urethra, go to the bladder, and then enters into the ureter. And it is very thin. By it can easily possible to reach to the renal pelvis. Look. Look. So flexible endoscope, they can push some leather. They stop looking down. All our pieces. Ability to get from the some extent, hold the hernia basket, move it out, then the bladder. And is also needed to some extent of fluoroscopic control is needed. The another option is which is nowadays
Your doctor
very
has
rarely
recommended
used.
that you undergo a shock wave lithotripsy. During this procedure, external shock waves are directed to the location of the stones in your body and which break the stones into tiny pieces.
The patient is lying in a table in a supine position there, and the kidney lies here. So if there is stone there, if from the back directly, if the wave, shock wave hit there, the stones can easily broken. But it is not possible all the time if it is big stones like 2 to 2.5 centimeter, or the stone is too hard. In that cases, the stone broken is very difficult. In the ESWL, it is also possible, but more energy can given. But there is some side effect. The side effect is, if you make a shock wave, it can damage the renal parenchyma to some extent. So that renal parenchyma is become healed by fibrosis. The patient subsequently develop hypertension. For that reason nowadays, so ESWL is very minimally is used, not all the time is used.
When you urinate, these pieces are then discharged from the body along with the urine. This animation shows the removal of stones in the kidney. There is usually no need for general anesthesia, but pain medication is administered for comfort during the procedure. You are placed on an operating table with your flank positioned towards the shock wave generator. Imaging with X-rays or ultrasound might be performed to pinpoint.
So before doing that, the CR or the ultrasonograph guidance, they can localize the stone, the beam focus center there, and directly hit it there by shock wave.
To the exact location of the stones. Focused shock waves are then transmitted to the stone through the skin. The stone absorbs the energy of the shock waves and breaks into pieces as small as grains of sand. Because of their small size,
that fragmented small stone subsequently passes through the ureter to the bladder and go expel out through the urethra.
These pieces can pass easily from the body along with the urine when you go to the toilet after the procedure. The procedure lasts about 45 minutes. If you have a large stone, it is quite common that you need multiple sessions to completely break it. Your doctor will inform you on the needed course of treatment. After the procedure, your doctor will see you for a follow-up to check if the stone completely broke up and got flushed out with the urine. You will be given a urine strainer to catch the bits of stone passed in your urine for further examination. Sometimes a stone fragment can temporarily get stuck in the ureter on its way down. This can cause some blood in your urine, congestion, and even pain. If you are in pain, use the prescribed painkillers and temporarily drink only small amounts to minimize the congestion. Contact your doctor if you develop fever. When the pain is under control, you can start drinking normally again.
So some other management needed whenever a ureteric stone is smaller in size, usually less than 1 centimeter or 0.7 centimeter in the pelvis, the stone is there, or the ureter, we usually don't go any sorts of surgical treatment. We first wait and see for natural expulsion, which is called the expectant treatment. That means you advise the patients take plenty of water and some jogging or jumping or whatever it feasible up to the individual is, and take plenty of water, which can causes the stone can migrate it subsequently can spontaneously expel out. But that expected treatment can potentiate or accentuate to some extent of medication. The medications are, if you prescribe some diuretics, low power diuretics like Fludac, 20 milligram daily for 7 to 8 days. You prescribe antibiotics because where there is a stone, there are to some extent obstructions. To prescribe some levofloxacin, 500 milligram daily for 7 days or 5 days. And you prescribe some uro-relaxant drug. That name is now available is tamsulosin, which is tamsulosin, the trade name is Uromax, 0.4 milligram once daily. You can prescribe that, having some selective alpha receptor blocker in the lower ureter and the trigon, which can relax the ureter and can help passage of stone from the up to the down. These are the expected treatment, but the patient never ever can allow the pain. For that reason, you can prescribe to some extent of painkiller along with it, like Voltaren, that means diclofenac sodium suppositories you can prescribe during the severe pain. He can introduce parenterally twice daily if needed. So that can help to treat the patient of the ureteric stones for expected treatment or natural expulsions. Because the urinary stones is possible, first thing is natural one, then you go for the minimal invasive, then if you fail, then go for the maximum scarring surgery. That means the open surgery is the last one, because every possibilities of recurrent stones all the times. For their reasons, minimal invasion first is conservative, that means expected treatment, then go for the minimal invasive, then go for the open surgery. So in case of ureter, so these stones, the techniques are PCNL, ESWL, and also the RIRS, all for the in the upper ureteric stones or in the pelvic stones. In the pelvic stone, they can treat by that methods. But in case of upper ureteric stones, the treatment is, one is expectant, the other is push bang. That means push a ureteric catheter or guider there. The stone is banged to the upwards, migrated up, then through the PCNL you can remove it out. One, push bang and go for PCNL. Or at the side, you can go with the RIRS, retrograde endoscopy, laser ablation, or go for laparoscopy, or go for ureteroscopic ICPL. But in the upper part is not possible all the time, because whenever the ureteroscope is introduced, by the flow of water, the stone can migrate it up. So rigid ureteroscope is not possible to go there and working there. In case of lower ureteric stones, like basic ureter junctions or the ureter, in the lower ureter, the ureter is ureteroscopic laser lithotripsy, ureteroscopic laser lithotripsy, or pneumatic lithotripsy, or laparoscopic lithotomy, or last one is the open ureterolithotomy. These are the options of ureteric stones. But we remember, whatever you do the surgery, always after do the surgery, must put a JJ stand through the ureter. Always. Otherwise, there is a chance of urinary leakage. Because whenever you do the open ureterolithotomy or laparoscopy, you open the ureter, make some stitches there, so there is some leakage made. But in case of endoscopic maneuver, there is no opening there. But you needed to do a ureter stand, because in the urerothelium is a very delicate urerothelial lining. Transitional lining is very delicate. Whenever you manipulate, it becomes edematous. For that reason, in the postoperative period, there is edema there, there is a colicky pain there, the patient feel pain. For that reasons, and whenever you do the endoscopic surgery, to some extent of urothelium is damaged. So for rest and healing, you must put a catheter stent over there and keep it there at least 3 weeks. At least 3 weeks minimum. So these are the options of the urinary stones. But in case of bladder stones, this is the big size stone there. So that big size stones, the stone is developed. Either the stone is migrated from the kidney, passing through the ureter, go into the bladder, and stay there and increase in size, one thing. Or the stone is developed in situ in the urinary bladder. So that primary stone is usually from the upper tract migrated down, the sterile urine is the primary stone. In the secondary stone is if there is the outflow of the tract is obstructions, like benign enlargement of the prostate, or the stricture urethra, or the metal stenosis, whatever is, or high bladder neck, whatever the causes of the outflow obstructions. So always there is a post-boiled residual stone, urine. So where there is a residual, there is the older urine is there. So there is chance of stasis causing the multiply the bacteria. There is infection and stone formation. One. Second thing is any foreign body in the urinary bladder, like if the patient having any surgery in the urinary bladder, there is a stitches like bacterial or catgut in the bladder wall. That is the needed to form the stone there. Or you put a catheter there, subsequently the catheter is removed, the balloon is ruptured there, a piece of balloon wall remains there. That bladder balloon wall subsequently encrusted and forms the stones. Or if you put a catheter a long time there, so there is sedimentations, encrustations, and the bladder balloon, catheter balloon become encrusted and form the stones there. So these are the possibilities of stones, cause of stone there. So the treatment of the stone is, in the bladder stone, the surgery, if it's a big one, you can go the traditional we do with the suprapubic cystolectomy. That means open the suprapubic region by fenestrine incisions, then skin and subcutaneous tissue is divided, the rectus sheath is divided in the midline, the rectus transversely, then the rectus muscles and pyramidalis are retracted, then head position of the patient head down, so all the viscera go migrated down, the urinary bladder is inflated with the normal saline, so bladder is pushed anteriorly because the anterior wall of the bladder is devoid of peritoneum. So directly you can approach without touching the peritoneum in the anterior wall, and you two stays which are there and make it step in wound, open the bladder, extend the incision, remove the stones, wash the bladder, put a catheter, and close the bladder, put a drain, close the wound. So this is the technique of open suprapubic cystolectomy. So this is a tricky question all the time in exam. The anterior wall of the bladder is devoid of peritoneum. So whenever the bladder is contracted, it goes down below the pelvic pubic bone. But when the bladder is distended, the peritoneum is go up, the bladder is full, anterior wall directly touches the muscles. So this is basic knowledge, must be know everybody. In the exam, lot of questions asked at the time. And other thing is the position of the patient is spinal, anesthesia is spinal and position is supine, but during opening the bladder, the head is go down. That means Trendelenburg position, head down. So if you push the patient head down, all the viscera migrated out, there is a less chance to injury the bladder intestine during opening the bladder. It is the safety for the patient and for the surgeon. So this is the traditional technique. But nowadays, the open surgery become obsolete one. Whatever the size of the stone is, they can treat by and minimally invasive techniques. So the techniques are, if the stone is larger one, that type of stone is usually needed. If you they throw the cystoscope, give the laser, the stone become broken, very minute granules, and wash it out with the elixir evacuator. Or if the stone is smaller in size, there is a mechanical lithotripter. Through the endoscope, there is a grasping forceps, or you can grasp it and make a pressure. The stone is broken down, then piecemeal they can remove it out, which is called mechanical lithotripsy. And another one is laser lithotripsy, endoscopic laser lithotripsy, cystoscopic litholapexy. Which one is directly pressure given broken is called the litholapexy. And another one is pneumatic lithotripsy. But the bladder pneumatic lithotripsy is very, very rare. Usually by mechanical litholapexy or laser lithotripsy. So these are about the urinary tract stones and treatment protocols. And another important thing, look, whenever you do an ultrasonography, look, one of the report which is admitted in Jalalabad Ragirabia Medical Hospital today, seen by me, do an ultrasonography, the patient pain in the right flank and lower abdomen. And this is a female patient. So after doing the ultrasonography, look the picture. Look some picture. So you look, this is the renal cortex and medulla on the one side. The other side is the cortex is damaged, but there is some black area that indicates the black means there is some fluids. So normally whenever the patient having a obstructive kidney, the patient having a pelvis is dilated, calyx is dilated, but here the pelvis and calyx are not dilated, but the fluid is collected in the renal capsules, So this is can easily differentiated that the patient is not the hydronephrotic kidney. In case of hydronephrosis, the pelvis is dilated there. They can easily see in the ultrasonography picture, and there is no collection like that. So it is most likely the patient having a pyelonephritis. So there is exudation. So look, there is a collection periphery of the renal tissues. So in the description they written there, the right kidney is normal in Simon position, bipolar length is 9.8, cortical echogenesis is mildly increased, cortical medullary differentiation is partially impaired, pelvic calcium system is not dilated, there is no evidence of any calculus or any sign of ureteric obstructions. Mild fluid collections noted in the perirenal regions. So ultrasonography is a very important tool to differentiate the renal parenchymal disease and obstructed kidney. For that reason, our main investigations, common investigation is one is ultrasonography, and during exam, what requisition asks some questions. What requisition you written for urinary system examination. So the requisition is, he always written there, ultrasonography of the KOB region if the patient is male with prostate and also MCC and PBR. MCC and PBR. That whole thing must be written there. Otherwise, your requisition is not complete. The MCC and PBR is indicate, say, what maximum systematic capacity the patient having maximum urge of micturations, and PBR is dictated what about the urine the patient can capable to expel out. he or she can capable to all the urine expel out or not, it can easily evaluate it by seeing that MCC and PBR. But be careful about the reports of MCC and PBR, because most of the sonologists does not having enough time to give during investigations. Say, take water, wait, and whenever maximum you come here and do the sonography, measurement it, and after maturation again come back. So same patient he needed to evaluate 2 times. There is no time. For that reason, they take some hurry, the report are not correct. Never ever treatment given by looking the sonography report of MCC and PBR. Always be remember about it. So best measurement of PBR is, direct. If you put a catheter after maturation, what amount is there? This is the PBR. This is the best methods, but it is the invasive one. Usually we don't do it. Another important thing is, in the urinary tract, we look, the common investigations are from the urine. Urinary tract investigation started not from the blood, started from the urine. The urine is urine, routine, and microscopic examination. Then that routine and microscopic examination, everybody must read the reports. What are the informations are there? We are commonly look about the RBC and past cell, these 2 things. But in the medical people, they look lot of things: kitten bodies, albumin, crystal, lot of things, what type of crystals are, everything they can look for that. But our surgical people, we needs to, the patient having urine sugar, the patient urine albumin, and past cell and RBC. If the patient having RBC, always remember, in case of female, you must query about the menstrual period, otherwise the diagnosis become wrong. And other thing is, what investigation other than urine RE is urine for culture and sensitivity. Be careful about it, because how can you send a sample? If the patient does not having catheter, it is okay, well and good. The patient go to the laboratories, the sterile test tube is there or container is there, maturate it directly there and send for culture and sensitivity. But in case of catheterized patient, how can you collect sample? This is the every individual, usually most of the junior doctors, they're wrong, or the sisters are wrong techniques, because they give the urine from the urine bag. No, never ever. You just clamp the urine bag to some periods. After that, disconnect the catheter from the bag, and from the catheter you can send the sample directly to the container. This is the technique for urine sample sent for culture and sensitivity. And another thing is, whenever a patient having a long time catheter placed in the catheter in the patient and needed remains there, in that time the catheter choice is very important one, because the catheter irritates the urethra. Whenever there is irritation, there is inflammation. Whenever there is inflammation, there is a deposition of collagen tissue, and that collagen tissue causing the stricture there, and the patient develops subsequently stricture urethra. For that reasons, you always careful about the catheterization. What thing they are having a less irritated, that thing you can use, like the silicone, all silicone catheter. It can keep at least minimum 1 month you can keep it in situ. And another thing is, whenever a patient having a long time catheter given there, and during removal, the tip of the catheter and the balloon, after deflation, remove it out and cut and send for culture and sensitivity. So that culture is very specific for the organisms. So this is about the catheterization and maintenance of the catheter. And another important thing is, we do the catheter and keep it continuous in the urinary bladder. But this is causing some harm for the patient. The harm is, whenever normal individual having some capability of the bladder is, the bladder is relaxed and contract by contracting the abdominal muscles and higher activity of the brain. But if you put a catheter, there is no distension, so there is no arc of micturations. For that reasons, it is better to, whenever you give the catheter, put the catheter inside, you clamp it after every 2 hours or 3 hours, 10 to 15 minutes open continuous, then again clamp it. It is better. The tonicity of the bladder can maintain. Otherwise, if you keep a catheter in the long time, 1 year, 2 years, the bladder become contracted and fibrosis of the mucous membrane, submucosal there, and ultimately the patient develop, which is called the thimble bladder. Thimble bladder, the capacity of the bladder become declining. So after removing the catheter, the patient micturate after every 15 minutes or every 20 minutes or half an hour, because the bladder elasticity is become lost. So that important thing you must memorize, otherwise you can miss it. So these are about the urinary tract and stone formation and the stone management. But look, one picture, you miss it there. So look, the picture is the pain. This is the back side, this is the front side. So from the back, the pain is from loin, anal region to in front, and this is from loin to groin or down. And this from loin to groin, and this is going into the testes or go into the Lansman steep. This is lower urinary tract stone presentations. This is upper urinary tract presentations. So whenever we look the IVU, we only look some. So you look some picture here. We look, this is an IVU picture, but here one important thing is, sometimes asked in the exam, by looking at an IVU, we don't able to say it is a stone. Always remember thing. By looking a single picture, never ever give the comment that it is a stagnant stone. No. If the patient is IVU picture with the ureter visualized, this is hydronephrotic kidney. If it is a plain X-ray along with that picture in side to side, then you compare that. My assumption is this is the hydronephrotic kidney along with the stagnant calculus there. Be careful about it. So stagnant calculus is given the opinion by looking the plain X-ray, not giving the IVU. In IVU, my opinion is it is hydronephrotic kidney at the obstruction at the level of the pelvic junction. And another important thing is, look, there is a black, but there is more white. There is more white. Sometimes in the exam, ask why that area is more white. So be clear the conception. Otherwise, you don't able to give that type of answer. Look, the picture is, this is a two-dimensional view. So the calyces, not only that direction in the lateral 1, 2, 3, 4, this, no. Some calyces are in the back. Some calyces are front. So the back calyce loaded with the contrast. So that whole calyce loaded with the contrast. So that area is more contrast there. For that reason is more white is there. For that reason it is called the end-on view. If you cut a tree branch and look their end, that is the end-on view. Be careful about it. This is end-on view. Close right now. So these are about the urinary systems of the renal, ureteric and bladder stones. So do you have any query? Please ask some questions. If you're capable to give your answers, or later on you can discuss after knowing your answers. So any question or any query?
Sir.
Yeah, Abid.
Hello, Assalam, sir. Sir,
Assalam.
thank you for such wonderful explanation, sir. I didn't understand why we will comment in IV result that it is a non-visualized kidney instead of non-functioning.
Yes, because if there is a kidney there, it is non-functioning. We don't able to see in the eye view because the contrast is not going there inside the renal parenchyma. It is not visualized. But if you do an ultrasonography or CT scan, you can look the kidney is shrink, smaller in size and place is there. Or the patient having an ectopic kidney. It's not in normal position. If the patient having a pelvic kidney, the kidney is not normal in position. So if we do look the picture of eye view, we're searching on the right kidney renal area. There is no kidneys there. For that reason, your answer is non-visualized kidney. I can confirm it by other investigation like CT scan, CT scan and isotope scanning. So if you isotope scan, you can look, there is some, if there is a less than 10% functioning, to some extent isotope scan can visualize the renal parenchyma there. For that reason I say, it is not absent kidney, it is non-visualized kidney.
Thank you, sir.
Okay, thanks. Any more?
Assalamu alaikum, sir.
Assalam.
Sir, my name is Jumbanuddin. Sir, I have a question. That is, sir, you say in every urinary system operation, we should give double J stent.
Yes.
Sir, my question is, sir, what is the importance of giving double J stent? What is its function?
Yes. Yes, it is a double J. Any more question? Yeah, you have?
No, sir.
Okay.
No, sir.
Yes, very good question. Because the shape of the stent is both end of the tube is J-shaped. For that is what it is called double. You look the tube, it is a hollow tube. One thing, first thing, it is a hollow tube. Second thing, the both end is J-shaped. So J-shape is whenever we introduce the stent, we push a guide wire inside the tube. So that guide wire causing it becomes straight. Whenever we confirm that the upper end reaches the pelvis, then we can remove the guide wire from the stent. So after removing the guide wire, it becomes king and it is J-shaped. So the advantage is that stent having multiple eye. One eye is there, one eye is there, one eye is there, one eye is there, one eye is there. The multiple eye is there, and the lumen is hollow. So the urine can directly passes through the hollow tubes from the pelvis to the bladder. Normally, ureter is empty by peristalsis, having a pressure and go down. And for the peristalsis, to some extent, there is relaxation. One area and then proximally there is contraction, relaxation, contraction, relaxation. So here there is no such effect more there. So if we make an incision there, so stone is there, we remove it out and we can repair with the stitches there. So if we don't push the stent, whenever the urine is passes through the ureter, the incision site become pressure and causing some urine leak to the exterior. Some urine go down, some urine go out. It is one thing. It is for open ureter lithotomy, so it can rest and easily heal the ureter. One.
Yes, sir.
But in case of non-incisional operation like ureteroscopic ICPL, there is no incision there. So we put the stent for that reason is
Sir, I can't hear your voice.
okay.
Sorry, sir, I can't hear your voice.
In case of ICPL or in case of ureteroscopic or RIRS, there is no incision in the ureter. But
Yes, sir.
also must be given the stent because during manipulation, the ureteroscope through the ureter become friction. So where there is a friction, there is inflammation. So inflammation presentation is swelling, rubor, dolor, tumor, functional. So there is a
Yes, sir.
mucous membrane becomes edematous. After doing surgery, whenever we remove the ureter
Hello.
subsequently the edema become reduced due to rest. For that reason, we every cases we push some stent there. And the removal of the stent, another technique I say is not, I forgotten it. How can you remove the stent? How can you
This is
remove
my
it?
question, sir.
So the removing is very easy nowadays because those operation I do, those stent given from below up retrogradely, the stent having a thread, fine thread there. The thread is keeping outside the urethra to some extent. So after 3 weeks, whenever the patient come in my chamber, just I hold the thread and pull it out. Finish. But if there is no thread, in that cases, needed to remove it out by introduce the cystoscope, cystoscopic stent removal. Introduce the endoscope, throw the urethra to the bladder, look the stent, hold with the forceps and remove it out. So this is the removal technique.
Yes, sir.
So do you understand?
Yes, sir.
Yes.
I understand that.
Okay.
Thank you,
Thank
sir.
you. Any more question?
No, sir. Assalamu alaikum.
Assalam. So if you have any question, you can query now or later on by an WhatsApp or email, which is subsequently given to your groups. And day after tomorrow, we can discuss about the lower urinary tract diseases like benign prostatic malignancy, stricture urethra. We can discuss day after tomorrow night at 10 p.m. Okay. So good night, everybody. Good night for study.
Good night, sir.
Good night.
Assalamu alaikum, sir.
Assalam.
Thank you, sir.
Thank you.